The leg is having pitting edema, and the skin is not good. The skin is a little fading, it's going to yellowish, and the hair has changed totally. It's kind of yellowish. So those are the things the child is experiencing.
Most times you can see there it is only mothers who bring the children. So you find the family support is a bit poor. Men involving themselves in alcohol, not in farming activities. So most times you find women involved in farming activities alone, of which the quantity they receive from the field is just very little.
Undernutrition is a well-known cause of high mortality and morbidity in children in sub-Saharan Africa. And specific to Uganda, 5% of children have moderate acute malnutrition. When we did an assessment of the quality of care of services at the health facility, we noticed that for the children that go to the facilities, only 50% actually are getting cured.
This project aims at improving the cure rate of children with acute malnutrition. So our intervention is supportive supervision. There is a team of 2-3 people visiting the health centers every 2 weeks approximately. And when they go there, they provide on-site training, they discuss clinical case, but they do also monitor that the care delivered is according to the international standards and also, of course, to the national guidelines of management. This is health system research. So we are trying to improve the performance of the health system, in this case the health center, but also we are doing a cost effectiveness analysis. So we are measuring all costs prospectively to assess whether our intervention is cost effective. There are 4 main partners. First one is Burlo, which is an institute of research in maternal and child health based in Italy. We are a unit of this institute and we are a WHO collaborating center in maternal and child health, appointed in 1992 by WHO. We of course collaborate with WHO in a number of projects. For example, we supported for the technical development of the WHO guidelines for children with severe acute malnutrition. Our main collaborator in the field is QAM, Doctors for Africa, the Italian largest NGO in Africa, working in Uganda since 1958. The other partner in the field is Makerere University of Public Health, a very well-known university worldwide. And also, lastly, the University of Trieste is involved, since Humphrey is doing his PhD at the university. Since the design phase of the study, together with our partners of Makerere University, we try to involve as much as possible key nutritional stakeholders of Uganda. And this was, of course, instrumental to get advice on how better to implement our study. And in fact, it proved to be effective because we got very good advice. And I would like to thank a number of people. And I would start with the principal nutritionist at the Ministry of Health, Dr. Jacent Azingwe, but also the district health team, especially the district health officer and staff of FANTA, and of course staff of UNICEF. And I've mentioned UNICEF is providing equipment, but also therapeutic foods for children with malnutrition. And in the field, we are also working with Concern, who has a large project on nutritional service in West Nile region.
This project is trying to fill in the gap of evidence that support supervision is a necessary intervention to improve on the management of children with acute malnutrition. Now, the project has a study coordinator who oversees 6 data collectors attached to the 6 health facilities. Now, at those facilities, they are working hand in hand with the in charge of the facility and the nutritional focal person at the facility.
When we came here in the morning, we found so many mothers gathered together, and it was the day is when they have their OTC day, the nutrition day, when mothers come to screen their children for malnutrition. So during support supervision, we check the information that they have, we check what the data that they have collected. In case there are errors, or in case we have identified a weakness somewhere, then we do on-job training.
We are enrolling children who are malnourished, and that is from the ages of 6 to 59 months. We collect the information where they're coming from, how much they're spending, and whether there's any person who supports the children apart from them who have brought them, and also get to find out where exactly they are living, the conditions that they are living in. And then we get to find out whether the children are eating properly and are able to eat these plumpiness that the health center gives them. That is the kind of information we collect, and then we note it down for the data collection.
Currently in our region here, we have realized a shift from family responsibility to laissez-faire. So it's affecting a lot, and that's why we are seeing increasing cases of malnutrition in our region. When you look at the patients and the health worker ratio, we are very few, we are constrained.
Due to lack of staff, things are not done in a way that they wish to be done. One person cannot do that alone. So it means sometimes it is only one person doing that work, leaves out other things, so takes only the weight in order to save time because the clients are many.
We supervise health workers intensively, like for this case, after every 2 weeks, we supervise them, and if there are any gaps that we identify, we sit with them, we brainstorm, and come up with a solution. We want to see whether that kind of mode of supervision improves the cure rate.
They get malnourished not because of food, but because of the poor caretaking. They don't wash their clothes, of which these children get sick with the diarrhea. They start having also, they get malaria. The parents are not really reliable. Some, they don't bring the children. They go for field work. They go for funerals. Some are even lazy to bring the children for facility to be assessed.
When there's a case of drop-up, we also come for follow-up. After finding the child, then we also try to talk to the woman again, then we also connect. So with this one here, these are our roles which we can play in the community.
Well, first of all, we hope that our study will have a benefit for children in Arua. Then secondly, if our study will be with positive result, we hope that the evidence produced will be translated into policies on supportive supervision. And then we hope that this will ultimately affect the health of children by improving it.